Assalamualaikum. Can we continue?
Yes, ma'am. Okay.
Alright, semua ada eh?
Ada.
Alright, okay. So we continue our lecture on Tumour Marker. Okay, so this is our learning outcome for today's lecture on Tumour Marker. We're going to define Tumour Marker, what is ideal Tumour Marker, the use, some common Tumour markers, and also the role of Tumour markers in carcinoma of unknown primary. Okay, so the mortality due to cancer has increased, okay, since the beginning of 20th century. Maybe because of the increase in the technology, we increase the detection of cancer. Okay, and it is one of the leading cause of death. And into 2020, 10 million deaths because of cancer. And the common cancer death are due to lung cancer. This is worldwide features, but what about in Malaysia? So in Malaysia, the breast cancer is the most common cancers in Malaysia. This is data from 2012 to 2016, but I don't know if in 2020 this pattern has changed. So, but in 2016, breast cancer is the most common cancers in Malaysia, followed by colorectal and also the lung cancer. So what is cancer? So cancer is a relatively the autonomous growth of tissue. So something, the tissue growth that cannot be controlled. So it grows autonomously. So what causes development of cancer? There are two things that happen for the cancer to develop. Number one is when there is activation of the oncogenes, activation or altered expression of the oncogenes. Oncogenes are the genes that cause cancer. So when it is activated, it can cause development of cancer. Or number two, cancer can develop because of the loss or inactivation of the tumor suppression genes. So in our body, there is genes that suppress the tumor. So when there is inactivation of this gene, this can lead to the development of cancer. So there is always so in a normal people without cancer, this always has to be in balance. And therefore we do not have cancer. But when this process are altered, this leads to the development of cancer. So the characteristic of cancer cells, it is not subject to the regulation. So it cannot be, the cell growth cannot be regulated, and it infiltrate the adjacent tissue, and also it can spread to the lymphatic or through the blood. So this is just to show you the difference between the normal resting cell, normal proliferating cell, and also the proliferating cancer cell. So as you can see in this normal resting cell, there is when the growth factor receptor is inactive, there is the intracellular signaling protein is also inactive. The gene regulatory protein also inactive. So the cell is inomorestin, so no proliferation of cell. But in cell with a normal proliferating cell, there is activation by this growth factor. So there is growth factor, so this will activate the growth factor receptor. So this activated growth factor receptor will activate the intracellular signaling protein. So this activated intracellular signaling protein will activate the regulatory genes. Therefore, it will cause the proliferation of the cell. But in cancer cell, what happens is that even though there is no activation of the growth factor receptor, there is abnormally active intracellular signaling protein. So it suddenly comes, okay, even without the activation of the growth factor receptor. So because of this abnormally active intracellular signaling protein, this will activate the regulatory genes protein, and therefore this will cause the uncontrolled proliferation of the cell that lead to cancer. Okay, and most of the time what we want is that we want to detect cancer very early, because if we detect early, this will give us the best chance for cure. But however, the current diagnostic procedure, current diagnostic investigation that we have can only detect tumors when it is already about 1 to 2 cm, but whereby at that time there are billions of cells already. Okay, what we want in the investigation of cancer is that we want early detection. So what is tumor marker? So tumor marker is substance that is found in high amount in either blood or any body fluids or any tissue that suggests the presence of certain type of cancer. So this is what we call as tumor marker. So the tumor marker can be in serum, can be in tissue, can be in any body fluids. But what I'm going to talk today is only about tumor marker that are present in the blood. So there may be tumor marker under histopathology, immunohistochemistry, but I'm not going to discuss about that in this lecture. So what is ideal tumor marker? So when we want to order tumor marker, of course we want something that is ideal, isn't it? So what is ideal tumor marker? So ideally tumor marker should be highly sensitive. What does it mean by highly sensitive? It means that when the tumor marker is highly sensitive, that tumor marker is able to detect cancer very early, or it is able to detect the cancer even though the cancer is very small. So this is the ideal tumor marker. Okay, number two, the characteristic of ideal tumor marker is it should be highly specific. So highly specific means that this tumor marker is able to differentiate between cancer and non-cancer. So it is very specific to cancer. So this is the second ideal features of tumor marker. The third one, we want that tumor marker to be organ specific, meaning that if there is rise in that tumor marker, we can identify that is the affected organ. So this is what we want. Number four, we want that tumor marker that correlates with the tumor stage or the tumor mass, meaning that the more advanced the tumor, the higher the level of tumor marker. The bigger the mass of the tumor, the higher the level of tumor marker. So that actually, we want that is that we want them to correlate. Okay? So this is all ideal one. We want the concentration that is proportional to the tumor stage. We want the concentration to change with growth or reduction of the tumor, meaning that after you remove the tumor, what you want is that the tumor marker should reduce according to the reduction in the size of the tumor. The concentration should reduce after remission. So this is what we want. That is ideal for the tumor marker. And then we want that tumor marker to correlate with the prognosis. The lower level means prognosis is good, high level means prognosis is not good. Okay? We also want them to be reliable, to have a reliable predictive value, meaning that the probability of no tumor exists in case of if the tumor marker is negative. So if the result is negative, we can say that the probability of tumor is there is no more. Okay, so no tumor, no with negative result means that there is no tumor. We can predict that there is no tumor. Okay, and another ideal features is that we want that tumor marker to have a short half-life, meaning that it reflects the current conditions of the patient, meaning that if you remove the tumor, okay, right away the tumor marker level is reduced. So if they have a short half-life, so this is what we want. However, in reality, all this ideal tumor marker is not available at the moment. So there's no one tumor marker that have all these ideal features. Okay? So that's why we have to be very careful with the tumor marker, because they do not have all these ideal features. So what are the uses of tumor marker? Okay, some tumor markers, they can be used for screening, but this is not for all tumor markers. Okay? For example, in patients with liver cirrhosis, they have higher risk to have to get hepatocellular carcinoma, isn't it? So what we can do is that for this patient with liver cirrhosis, we can use AFP as a tumor marker to screen them for the presence of hepatocellular carcinoma. But this AFP is not useful to screen the general population or in those who are asymptomatic. It is only suitable to be used for screening in certain individual with certain risk. So remember, tumor marker is not suitable for, in most cancer, tumor marker is not suitable to be used for screening. So except for this one that I mentioned. Alright, number 2, some tumor marker can be used for diagnosis, and again, this is not for all type of cancer. Okay, among the example of tumor marker that can be used for diagnosis is like the beta ICG for cholangiocarcinoma, AFP for hepatocellular carcinoma, calcitonin for carcinomedullary carcinoma of thyroid. So these are among the example of tumor marker that can be used for diagnosis. However, still, with this also, you still have to take a lot of precaution whenever you want to interpret the result. Okay, because of the lack of this specificity and this sensitivity of the tumor marker, and also sometimes they could also be a false negative. Okay. Tumor marker can also be used for tumor localization, and also again, this is not for all tumor markers. There are some markers that are specific, such as PSA, prostate specific antigen. This PSA, it is specific to prostate. However, it is not specific to prostate cancer. So meaning that when PSA is increased, you know that there is increase because of prostate. You cannot say for sure that this increase in PSA is due to prostate cancer, because the benign prostatic hyperplasia can also cause increase in PSA. So you can actually localize, but you are not sure whether it is malignant or not malignant. So you can localize the tumor, but you cannot say that it is malignant. And other uses of tumor marker is for tumor staging. Okay. Some tumor markers, they are related to the stage of the cancer. For instance, the CEA in colorectal cancer, it correlates with the Duke stage. Okay. And the most important clinical use of tumor marker is for monitoring the effectiveness of the treatment, whether monitoring the effect after surgery or after you give the chemotherapy to the patient. So, by looking at the level of tumor marker, we can say whether the treatment is success or not success. Okay, next, another use for tumor marker is to detect the tumor recurrence or remission. So this is the most important clinical use of tumor marker, where the tumor marker may, when there is decrease in the tumor marker back to normal, you may say that the patient is having a complete remission, or you have removed completely the tumor. Or when there is persistent or renewed increase after a short drop, this could be due to residual tumor or metastasis. Or you can also check for the presence of recurrence when there is renewed increase after certain period of normalization. So this is the most important use of tumor marker. And we can also use tumor marker for to look at the prognosis. For some tumor marker can give you prognosis, where the high or increasing concentration will indicate unfavorable prognosis. So there are a few important points that you have to bear in mind whenever you want to interpret the results of tumor marker. Okay, number one, tumor marker kinetic is more important than values, meaning that what you have to do is that you have to look at the serial values of tumor marker. So when there is increasing in trend or decreasing in trend, that is more important than the value of the tumor marker, whatever the value is. But if the trend is increasing or the trend is decreasing, that will give you more important information. Okay. So increase in concentration is significant even though it is in normal range. Yes. So it is like, if you measure the tumor marker, okay, it is within normal. It is still within normal range, but if you look serially, there is increasing trend. So this will give you a clue that something wrong might happen. Okay, so you have to be more alert when there is increasing concentration, even though it is still in normal range. And number 3 important points that you have to bear in mind is that some tumors, when they metastasize, they will stop releasing the tumor antigen because when they metastasize, they lost their original antigenicity. So you may confuse this. You may say that, okay, since the amount of tumor marker is reducing, patient is actually improving, where actually the patient has got metastasis. So this is also you have to keep in mind, okay, because during metastasis the tumor lost its antigenicity, it may stop releasing tumor marker. So you may confuse this, you may confuse and say that patient has improved. Okay, another point that you have to remember is that tumor marker may be elevated due to excretory problem. Okay, most of the tumor marker that are excreted either through the kidney, through the liver. So when there's problem with the kidney or the liver, the level of tumor marker may be elevated. Not because they are having cancer. The tumor marker elevated because they cannot excrete. Okay? So this is also you have to bear in mind. Okay, disturbance in blood supply to the tumor marker can lead to fluctuations in the tumor marker. So when you want to monitor patients with cancer, sometimes you may find that the level of marker fluctuates. So you may confuse this with whether improvement or worsen of the condition, but actually that happened because of the disturbance in the blood supply because of the tumor. So that also you have to bear in mind. Okay, some drugs, they may interfere with the level of tumor marker. So for instance, the anti-androgen therapy in carcinoma of prostate can inhibit the PSA production. So when you treat patient with anti-androgen therapy, okay, you have to be careful with the interpretation of the PSA. And rectal examination may increase PAP or PSA. So that's why if you want to take blood for PSA, you better take the blood before you do rectal examination. Or if you have done rectal examination, you should wait at least for another 3 days before you take the sample for PSA. Okay, and if you were to take sample for prostatic acid phosphatase, okay, you must store the sample at 4 degrees. Okay, not to let the sample at the room temperature because that will disintegrate and give rise to a falsely low result. Okay, the last one, okay, use of different test kit for determination of the same parameter can imitate tumor remission or progression. So this commonly happen, okay, when you see this patient in one hospital. So that hospital is using this type of analyzer, this kind of sensitivity and so on, you get the result of tumor marker. So when you see the patient at the other hospital that are using different kind of different method of measuring the tumor marker, so you cannot actually compare the result of this tumor marker from this hospital and another hospital. So if you want to monitor your patient, you must take this line of tumor marker from this hospital and then you follow up the patient and do the tumor marker test at the same place, at the same hospital, that using the same analyzer. Then only you can compare. So you cannot compare the result of tumor marker that use different method or different analyzers, because that will give you a different result that may imitate the tumor remission, where if the level is lower, or tumor progression if the level is higher. So this is commonly happen when I did receive call from some MO saying that the results of this tumor marker is very far different from the one in HTAA. So I said what you have to do is that you take this current one as baseline, then you repeat after this and see the pattern. You cannot compare the results of tumor marker done in IUM and compare that to HTAA because we are using a different method and different analyzer. So this is the examples of the common tumor markers. But what I'm going to discuss today, I'm just going to discuss some tumor markers that we offered here in IUM. So this is the common clinical uses of some tumor markers, and if you can see, the red one are the tumor markers that we offered, that we mostly offer in our hospital. So most of these tumor markers, if you notice, not many of them can be used for diagnosis and also screening. So among the tumor markers that can be used for diagnosis include the beta HCG for choriocarcinoma, AFP and beta HCG for germ cell tumors, AFP for hepatoma, LDH for lymphoma, and PSA for prostate. So there are not many tumor markers that can be used for screening and also for diagnosis. Most of the tumor markers are used for monitoring and also to check for the response to the treatment. And you have to bear in mind, there are also some benign conditions that are associated with trust in tumor marker. Therefore, when you want to interpret the result of tumor marker, think of this possibility as well. The tumor marker may be elevated, but it is only because of some benign condition, not due to malignancy. Okay, so we move on to the first one, that is the alpha-fetoprotein. So alpha-fetoprotein, it should be in general population, it should be less than 10 to 20 nanogram per mil. The use of this alpha-fetoprotein is mainly, as I mentioned earlier, mainly for detection and monitoring of the hepatocellular carcinoma. So we can use this alpha-fetoprotein for screening of patients with cirrhosis, because we know that cirrhosis patients, they are at risk of getting the hepatocellular carcinoma. So for this cirrhosis patient, we can do alpha-fetoprotein every 6 months to screen for the hepatocellular carcinoma. Also, we can use EFP in diagnosis of patients with non-seminal metastatic germ cell tumor. So this is among the tumor markers that can be used for diagnosis of testicular germ cell tumor. So in testicular germ cell tumor, there will be increase in EFP and also increase in beta HCG. So when we combine EFP and beta HCG, this will increase the sensitivity for detecting the tumor. Okay. EFP is also used for diagnosis of neural tube defects in neonates, and also not to forget, you have to bear in mind tumor. There are also other tumors that can cause elevation of EFP, like the gastric carcinoma, colorectal cancer, biliary and pancreatic carcinoma, and some liver metastasis. So always, when you do tumor marker, you always have to bear in mind of this possibility. There could be cancer, there could not be, also not cancer. Beta HCG, mainly we use beta HCG for in pregnancy, for detection and monitoring pregnancy, to check for ectopic pregnancy, and also for the abortion. So this is the main use of beta HCG. But beta HCG can also be used for diagnosis of and also monitoring of germinal tumors, like in the trophoblastic tumor, in testicular tumors, and also only 10% in seminoma. So beta HCG is one of the tumor marker that can be used for diagnosis, okay, for choriocarcinoma. So in choriocarcinoma, beta HCG is positive, AFP is negative. So this is contrast to the testicular germ cell tumor just now, where AFP is positive, HCG is positive. So we use beta HCG for the detection of the trophoblastic tumor in patients with hydatidiform bone. Right, CEA. CEA is mainly used for therapy check and also for monitoring of patients with colorectal carcinoma. So the good things about CEA is that it correlates with the tumor stage. So it correlates with the deep stage of the colorectal cancer. So you can actually repeat the test of CEA in patients with colorectal tumor every 6 to 8 weeks. 6 to 8 weeks after operation. So when there is any renal increase, that would indicate the progression, recurrence, or metastasis of the tumor. Right, but not to forget, CEA may also be elevated in small cell lung carcinoma. So CEA is not specific to colorectal cancer. So, and also CEA can be elevated in various cancer, not only colorectal lung cancer, but may also be elevated in gastric cancer, breast cancer, pancreatic, ovarian, uterine, and so on. So there are so many cancers that can cause increase in CEA. Therefore, CEA is not recommended for screening of this cancer. And also CEA may also be elevated in non-cancerous condition. Even in smoking, also CEA may be elevated. The prostate specific antigen. So PSA is the only tumor marker that is organ specific. So it is specific to prostate, but it is not specific to prostate cancer. So what we can do is that we can use this PSA for screening and also diagnosis of prostate cancer by combining this finding with the digital rectal examination. So this will increase the sensitivity to 96%. And in some center, they may measure the ratio of free to total PSA, where there is increase in total PSA and low in free PSA, they are associated with higher risk of prostate cancer. So we can also use PSA for the monitoring of the patient after treatment. So by right after operation, PSA shouldn't be detected after 6 weeks. Then you can follow up every 3 months to look for the recurrence or presence of metastasis. And you also have to bear in mind, PSA may be increased in non-cancerous condition like in prostatitis, BPH, and also the prostate adenoma. The increase in PSA does not necessarily means that patient is having prostate cancer, but it is prostate problem, but not necessarily prostate cancer. Right, CA125. So mainly used in ovarian cancer, where in ovarian the CA125 can differentiate benign from malignant disease in women with palpable ovarian mass. So meaning that if you have a patient with palpable ovarian mass, you can use CA125 to differentiate between benign and malignant disease, but not to do this for the screening of general population. And CA125 is highly sensitive to serous adenocarcinoma than to mucinous adenocarcinoma. Okay, remember, it's not useful for screening of asymptomatic population, but if the patient is symptomatic with presence of palpable ovarian tumor, then we can use CA125 to look for the ovarian cancer. Okay, we cannot use CA125 to differentiate ovarian cancer from other malignancies. And have to bear in mind also that CA125 may be elevated in other cancer like endometrial, colon, or breast, and also lung cancer. Okay? And these are the benign conditions that can cause increase in CA125, like endometriosis, breast disease, normal pregnancy, menstruation. Even menstruation can also increase CA125, hypothyroidism, and even heart failure. So mainly we can use apart from the diagnosis in those who are symptomatic, we can also use CA125 for the therapy check and also monitoring of patient with ovarian cancer. Okay, CA153. So we mainly use CA153 for breast cancer. But okay, we should not use CA153 to diagnose primary breast cancer. So we mainly use CA153 for therapy check and monitoring of patient with breast cancer, but not for diagnosis. So this CA153 is elevated in 70% of female with metastasized breast cancer, but only 30 to 40% of with non-metastasized breast cancer. So it is the elevation is more in those with metastasis breast cancer. Okay. We have to also bear in mind that CA153, apart from breast cancer, it may also be elevated in other types of cancer. So that's why it is not suitable for screening for breast cancer. So it can be elevated in pancreatic cancer, lung cancer, ovarian cancer, and so on. And it may also be elevated in non-cancerous condition like liver cirrhosis, chronic hepatitis, acute hepatitis. CA99. So we mainly use CA99 for pancreatic carcinoma. So it is a primary marker for pancreatic carcinoma. Basically, we use CA99 to look for the prognosis of the patient, where if the level is more than 1000, the tumor is unresectable. Okay? And it's also the CA99 also correlate with the tumor size and also staging. Okay, the CA99 is not specific to pancreatic cancer also, so it can be elevated in gastric carcinoma, biliary carcinoma, colorectal, and also liver metastasis. So it is not specific to pancreatic cancer. And CA99 may also be elevated in other non-cancerous conditions like acute hepatitis, cystic fibrosis, even endometriosis may also increase the CA99. Okay, what about tumor markers in cancers of unknown primary? So among the common indication, what I would say indication of request for tumor marker, most of the MOs who called me for to request for tumor markers because they want to locate where is the tumor because they don't know where is the primary. So basically, these cancers of unknown primary, it accounts for about 3% of new cancers. And in the study from the autopsy sample, most of frequent site of the tumor of the cancers of unknown primary are from the lungs, pancreas, colon, kidney, prostate, and breast. And this type of cancer, they actually we cannot use tumor marker to screen them because like the CEA, it may be increased in lungs, it may be in colon, so it may be in pancreas, so you cannot actually locate the tumor by using that tumor marker. And most of the patients with cancers of the unknown primary, the survival rate is poor, but those who have a long-term survival, they are those with atypical presentation, but with a cancer that is highly treatable malignancy, like the choriocarcinoma, it is treatable, isn't it? So, so it is worth to detect that kind of cancer because it is treatable. So the aim of investigation in the cancers of unknown primary is actually to avoid missing the treatable malignancy. So this is among the tumor markers that are known to be helpful in the diagnosis of cancers of unknown primary. The HCG for choriocarcinoma, HCG and AFP in germ cell tumor of testis and ovary, PSA for prostate cancer, and CA125 in ovarian cancer. So these are the only tumor markers that are known to be helpful in the investigation of cancers of unknown primary. However, even though it is helpful, however, there are also shortcomings with this tumor marker because 80% of testicular seminoma and 20% of the non-seminomatous germ cell tumor, treatable germ cell tumor or polydifferentiated adenocarcinoma, they are markers negative. So even though they are negative, even though they have this cancer, they can have negative of this tumor marker. And also CA125, it can also be elevated in multiple non-malignancy conditions. So even though they said that this is helpful, but still there are also shortcomings about this tumor marker. So for this, the ESMO or the European Society of Medical Oncologists, they come out with a clinical practice guideline. So in their guideline, they have outlined the steps in the investigation of the cancers of unknown primary. But the first step should be the thorough medical history and also physical examination. And step number 2 is to do the basic blood and biochemistry analysis. So we just have to do the basic blood investigation, okay, like the full blood count, all the basic one, the LDH level, the serum protein, what else, the hemoglobin, the liver function test, calcium. So you just do the basic blood and biochemistry investigation. Number 3, okay, they should proceed with CT scan of CTTAP. So this should be the number 3 step in the investigation of cancers of unknown primary. Then in female, you can proceed with mammogram. Okay. Then only you work up for the cancer of unknown primary. So the workup of this CUP so would include after mammogram you can proceed with breast MRI. Then only they would suggest the alpha fetoprotein and HCG only in those with midline metastatic disease. Okay, and PSA in males with adenocarcinomatous bone metastasis. So this is what is suggested. So it is only limited use of serum tumor marker in cancers of unknown primary. Then only I would suggest head and neck CT scan, endoscopy, colonoscopy or GTS. Then they also suggest the chromogranin A in patient with neuroendocrine tumor. Then only other additional diagnostic pathology. So this is what is suggested by the ESMO. Okay, but in NICE guideline is guideline for UK and also Wales. So they come up with the initial diagnostic phase and the second diagnostic phase. So in the initial diagnostic phase, similar to the ESMO guideline, they suggest they ask us to do the comprehensive history and physical examination, followed by basic blood and biochemistry investigation, like blood count, use creatinine, liver function test, calcium, LDH, urine. And the third one for NICE, they add in myeloma screening. So myeloma screening is important also because that could be one of the commonest cause of cancers of unknown primary. So you have to screen for myeloma. So meaning that you have to proceed with the serum total protein and albumin, then you have to proceed to serum protein electrophoresis and so on to screen for myeloma. Then only the endoscopy, whether OGTS or also colonoscopy, then they would suggest CT TAP, CT TAP. Okay, after that only they suggest PSA in men, CA125 in women with peritoneal malignancy or ascites, and AFP and CG in those with midline nodal disease. Okay, then followed by testicular ultrasound, and also biopsy and standard histological examination. So basically, more or less, the ESMO guideline and NICE guideline are quite similar. So the difference is that NICE add myeloma screening in its guideline. However, okay, the NICE also mention it clearly. Do not measure tumor markers during diagnosis except for FP and beta ICG in patients with presentation compatible with germ cell tumor, particularly in those with mediastinal or retroperitoneal mass in young men. Okay, or FP. So FP in patient with presentation compatible with hepatocellular cancer. SA in men with presentation compatible with prostate cancer. CA125 in women with presentation compatible with ovarian cancer. So basically, they do not suggest doing tumor marker for cancers of unknown primary unless there are some presentation related to that tumor. Okay, and NICE also give us the second diagnostic phase. So after you finish the first one, then only you proceed with the second diagnostic phase that include the endoscopy, mammogram, breast MRI, PET scan, immunohisto, and also gene expression based profiling. So in our place, this is not yet offered as a diagnostic in diagnostic service. Okay. And also for those with specific clinical presentation, like those with intrapulmonary nodules of lung cancer, so they would suggest the flexible bronchoscopy and video-assisted thoracoscopic surgery, and those in malignant peritoneal disease, they suggest for tissue for histological examination. So this is the guideline from NICE. So in Malaysia, we do not have a specific guideline on the cancers of unknown primary or guideline on the use of Tumour Marker. Okay, so yeah, we come to the end of the lecture. So what we can, the lesson, at least, you know, if you go back from this class, at least I want you to remember this. Okay, there is no ideal Tumour marker. This is number one. Number two, sometimes you may combine Tumour markers to improve the sensitivity, like SCG and AFP. Okay, and screening and making diagnosis using Tumour marker may be useful only in certain group, you know, like the AFP for screening of hepatocellular carcinoma in patients with cirrhosis. And most of the Tumour markers, they are useful for therapy check and monitoring. So this is the main use. This should be the main indication for ordering the Tumour marker test. Okay, only selected Tumour markers are recommended in the investigation of carcinoma of unknown primary, and that even for that Tumour markers also, there must be some indication, like patient must have some presentation of that tumor, then only it is indicated for you to order the Tumour markers. And therefore, because of this, we still need support from other investigation in order for us to screen, to diagnose the tumors. Okay, so Tumour markers cannot be solely used for screening and also for the diagnosis of tumor or cancers. All right, so that's all. So is there any question?
Any question from the floor?
Any question? Yeah, so if no question, I hope that you get the home message from me. You know, if you were to screen for, if you were to order Tumour marker, choose the Tumour marker carefully. So and please bear in mind that mainly Tumour markers are not for diagnosis and for screening, but it is useful for monitoring of the treatment or monitoring the progress of the cancers.
Dr. Hafizuddin want to ask question?
Yes, anything?
Do we have a CA153 available in Malaysia?
CA153 we have.
So
We have for monitoring of breast cancer.
Okay.
Okay. So always please remember, since you all are IUM postgraduate student, so if you have anything to ask about Tumour marker, you can always call me, because I give a memo that for those who want to order Tumour marker, more than one marker, you have to call me so that we can actually discuss what is Tumour marker that is best for you to order.
Yeah.
This is also to help us, because Tumour marker is quite expensive, so we don't want the clinician to just order any Tumour marker that may not be indicated. So we can actually discuss on the need of the ordering of the Tumour marker. All right. So any more question?
Sorry, Dr.
Yes.
Zamzila.
Yeah.
Amira first year surgical.
Uh-huh.
I just want to ask, this is not regarding the Tumour marker. Just to ask you if, let's say, for us in surgical, what's the best, I mean, like the suitable reference or books that we going to use for our reference?
For what? Reference for?
Pathology.
Pathology. I don't know about the general pathology, but for chemical pathology, there is one simple book that you can read. That is the or primer of chemical pathology. But I don't know whether that is useful for a student in surgery. But for student who is pathology, for pathology candidate who want to sit for the exam, the entrance exam, I suggest them to read that a primer of chemical pathology book. So it's just a simple book that covers most of the things in chemical pathology. But for if you were to read a specific topic, like tumor marker, you can read in the clinical chemistry book. It can be TITS, clinical chemistry book, or Kaplan book. IETZ, TITS.
Kaplan.
Kaplan tu another book. Kaplan clinical chemistry juga. TITS pun clinical chemistry juga. But I don't know what is your coverage for your, for your exam in pathology. I don't know much. But what are the common questions that come up previously about pathology?
It's about the thrombosis.
Oh, thrombosis must be general pathology. General pathology, then
Inflammation.
Maybe baby Robin pun okay dah kot, because you are not going to be pathologist kan. So for general things, I think baby Robin pun okay.
Because to read Robin is very lengthy.
Yes, because you just read that baby Robin je lah.
Baby Robin.
Kalau for macam thrombosis apa semua tu, I think baby Robin is enough lah.
Okay.
Because you can recall your undergraduate things kan, cuma macam nak where to start, macam nak trigger kan. So I rasa baby Robin tu is enough lah for you all. Kalau yang general peto lah.
Okay, thank you.
I don't know if there is any other simple book for you. You may ask Dr. Aziana as well, because she's histopathologist. Dia memang ajar general pathology.
Okay, thank you.
Okay, so when is your exam?
17. 18 and 21st of June.
June, so soon.
Yeah.
Right. Okay. So all the best to you all. Inshallah, I pray that all of you pass this exam. Inshallah.
Amin.
Amin. Okay. Alright. Okay. No problem. But if you have anything to discuss with me, you can always call me. No problem. Or message me lah, senang. WhatsApp ke. If you have any question, alright?
Alright.
Okay. Thank you for your attention.
Thank you.
Assalamualaikum warahmatullahi wabarakatuh.